Thank you, Aileen, and to the team in Safefood for inviting me to open this workshop today. I'm really looking forward to hearing from the experience on both sides of the border. So from Louise from the INDI on the practicalities of implementing healthy meals in the early years services, and Colette from Northern Ireland on the Henry Public Health Promotion Initiative. Both really good examples of initiatives undertaken to improve the nutritional intake for children. As we come towards the last few years of the Obesity Policy and Action Plan in Ireland, or known as OPAP, a review of new and existing evidence will be undertaken to support the direction of a new strategy. So we're really fortunate that we're joined by such an eminent researcher, Dr. Anna Lene Seidler, who is joining us from the Southern Hemisphere, no less, to describe her experience of research in the area of obesity. So from a policy context, as we know, 1 in 4 school children are overweight or obese. And according to the WHO report last year on obesity, the rates of obesity in the last 40 years have trebled. In Ireland itself, in the last 10 years, the rates of obesity in teenagers has increased from 18% up to 24%. And it's no mean feat to make it into the top 10, but unfortunately for us, Ireland is ranked number 9 out of the 51 countries detailed in the report. As many of you know, as healthcare practitioners, the consequences of obesity are immense. In addition to mobility and musculoskeletal problems, there is a reduction in quality of life, and people living with obesity are at higher risk of developing heart disease, diabetes, and up to 13 different types of cancer have been linked to obesity. And very often, dealing with children, these comorbidities are often overlooked. Stigma, bullying, social isolation, and mental health issues are often compounded when living with obesity, and is often worse in those who are already socially deprived. And this is why it's so important that we take steps now to make positive changes for the health and well-being of our children on this island. Environmental factors were very much called out as one of the key drivers in the rise of obesity, and there was good agreement amongst many of the speakers that attended the European Congress on Obesity in Dublin in May of this year. And a systems-based approach was called for because, as to date, the investment in strategies focused on the individual have not yielded any real change. So this is not a new phenomena, and the Healthy Ireland framework was launched back in 2014 to address health inequalities and change the environment in which we live so that people could be empowered to make healthier lifestyle choices. And very much the focus was on supporting cross-government working and engagement with local communities and other agencies to achieve this change. The Obesity Policy and Action Plan was one of the first policies to take this cross-sectorial approach, and Safefood is one of the key stakeholders on the Oversight Implementation Group. Collaboration by the Department of Health with Safefood and other government departments such as the Department of Social Protection, the Department of Education, the Department of Children, which is now known as DCE-DIY, and other agencies has resulted in many projects that are being delivered all over the country. Nutrition standards have been developed by Safefood with the Department of Health, using the FSAI food-based healthy eating guidelines, both for the 1 to 4-year-olds and for the general population, so that they could be used to deliver hot school meals in the early years services and in schools. The Department of Social Protection has introduced the free school meal scheme originally in the DESH schools as a result of the cost of living crisis and to support those who are at risk of poverty. And from September of this year, this is going to be expanded to nearly 230,000 students starting in the autumn. The Food Poverty Network is led by the Safefood team, and food parcel guidelines have been developed, and other resources are available, such as the 101 square meals, which are really valuable to those who are providing meals and other supports to families who are living at the risk of poverty. I think the Safe Food Start campaign deserves a special mention. I think every parent in the country can resonate with the adverts that describe having to say no to the request for treats time and time again, and trying to come up with ideas for quick and healthy meals. And it is a real challenge for everyone, and myself included, to keep saying no when the exposure to foods that are high in fat and salt and sugar are everywhere that we go and are part of every activity that we undertake. And I feel like it's very hard to rein it back in, particularly following on from COVID. So in Ireland, we're now 7 years into the Obesity Policy and Action Plan, or OPAP, and a review was conducted last year by the University of Cork Public Health Department and the Department of Health. So it was recognised that significant investment has been made by the government in support of the plan. And some examples of that would be the uplift of the numbers of lactation consultants that are available. We've got 30 new posts that were funded from 2021 to support new mums in their breastfeeding journey, and the establishment of paediatric obesity multidisciplinary services in CHO5 and CHO7 as part of the Sláinte Care health reform, which aims to deliver care closer to home. In addition to that, 19 healthy communities have been established around the country that encourage participation with the local community, local government, to support people who need education and need advice on how to improve their lifestyle and offer them opportunities to improve their well-being. Each of these healthy communities has a dedicated food and nutrition worker that will work with the communities and continue to deliver on the Healthy Food Made Easy programs and on the Safe Food Community Food initiatives. Like our European colleagues that presented at the conference last month, changing the obesogenic environment around us is proving to be very difficult. One of the measures that have been taken is the project called Best Remap. This is an EU Commission joint action between 17 member states that is looking at the restriction and monitoring of foods marketed to children. Ireland participated in Work Plan 6, and it was only yesterday that I attended a workshop on how we can apply these tools to look at how marketing is conducted in our own area. The full outcomes of this project are due in September of this year, and this vast amount of work will help to inform us how to take this approach forward. Only this year, the new Commission Naman was set up to look at online media and safety codes, replacing the Broadcasting Authority of Ireland. So the Department of Health expects to engage with the Commission around the marketing of foods high in fat, sugar and salt, and infant formula. Last year, the FSAI Food Reformulation Task Force started on a 4-year programme to encourage voluntary participation by food industry partners to reduce the amount of sugar, salt and fat in foods to improve the quality of food offered to children. So I hope that gives you a whistle-stop tour of some of the policy initiatives that are being undertaken in Ireland at the moment. There's some good examples of work that has been done, but there is a lot more to achieve. It has been a privilege for me to work with my Safe Food colleagues over the last few months since I joined the department, and I'm very much looking forward to our continued collaboration on the existing obesity policy and in designing one for the future. So I think this is a good junction now to hand back to Aileen so that we can hear from the other speakers on how to support healthy eating in our children.
Thank you, Fiona, for that really comprehensive overview of the current context and some of the strong initiatives that have been happening in recent years. I'd like now to welcome our first speaker, Colette Doyle, Colette is the coordinator for the Henry programme in Northern Ireland. And for those who, in the Southeastern Health and Social Care Trust area rather, for those who aren't familiar with Henry, it stands for Health, Exercise and Nutrition for the Really Young. And it's a unique intervention to support both parents and carers to provide healthy and happy environments for young children. Colette has a long history and a background in nursing and as a midwife working in both Scotland and Northern Ireland, and has recently moved into more managerial roles before moving on to her coordinator role for Henry. So really looking forward to seeing how the Henry programme is going in Northern Ireland, Colette.
Hello everybody, my name is Colette Doyle, and as has been said, I'm coordinator for the Henry project in the Southeastern Trust. So basically I'm just going to talk about Henry. So as already has been said, Henry stands for Health, Exercise for the Really Young. So when did Henry begin? Well, Henry started in Leeds in 2009 as a key strand of Leeds City Council citywide healthy weight strategy. The strategy focused particularly on the early years. It started as face-to-face groups initially, but then when COVID happened, everybody had to improvise, and so they went online. So a 2019 Oxford University study showed a significant and sustained year-on-year decrease in obesity rates at reception. Henry's holistic approach and commitment to quality has led to commissions from more than 70 local authorities and health boards across the UK, and now also the 5 trusts in Northern Ireland. Next slide. So Henry, the programmes and workshops that Henry offer are Healthy Families Right from the Start, which is aimed at 0 to 5 years, Healthy Families Growing Up, which is for 5 to 12 years, Fussy Eating workshops, Starting Solid workshops, Healthy Teeth workshops, and Preparation for Parenthood. The programme that has been commissioned by Northern Ireland and that I'm going to discuss is the Healthy Families Right from the Start, which is aimed at the 0 to 5 years. So it's widely accepted that all children need a healthy and happy start to be able to flourish in their lives. And our mission is to support a healthy, happy start and lay the foundations for a brighter future. Henry adopts a unique, flexible and holistic approach to working with families. This is underpinned by the evidence on risk and protective factors for early nutrition, child obesity and child development. So the Henry applies behaviour change models into a supportive and effective approach that increases parental confidence and their ability to provide a healthy start for their child. Henry supports physical and emotional well-being and covers nutrition, physical activity, portion sizes, screen time, looking after yourself, exploring feelings and managing challenging behaviour. Parents are supported to set realistic goals for change at their pace based on their knowledge of their own family and circumstances. These could relate to being more active, eating more healthily, or putting in place good routines or parenting strategies. Parents' ideas are valued and integral to the programme. They are supported to choose which ideas or change will work best for them. Does it work? Well, there's over 8 published academic papers substantiate Henry's aim, which is to make positive changes for parents and children. More than 13,000 parents have joined the programme in the UK, and the majority of families who have completed the programme are now leading a healthier lifestyle. So the referral criteria that we aim for is 20% age 6 to 9 months, 60% age 1 to 2.5 years, and 20% age 2.5 to 5 years. And also children and families are ready to change based on motivation and readiness to change. We also look for rapid weight gain in a young child, or if they're above the 99th centile, or else if they're 2 major centiles above their length, or their child has a high BMI. If the answer is yes, then we would ask professionals to make a Henry referral. We also go by professional knowledge. Most of my referrals would be from health visitors and school nurses. So if the health visitor has concern about family lifestyle, poor diet, lack of physical activity, parental weight status. As we know, maternal obesity is the biggest risk factor for child obesity. Concerns about a child's eating habits. For example, mother is concerned that their child's wearing clothes much bigger. Lack of enjoyment of family time. If family time, meal times are stressful for parents. Parental anxiety about feeding their child. Low confidence around providing a healthy lifestyle. So when a family signs up for the Henry program, they're given a bag with the Henry toolkit. So the pack includes a Healthy Families book, which is excellent. There's information about understanding the child's needs, parental mental health, examples of empathetic responses that parents can give to their children, ideas for increasing activity levels. There's lots of recipes, and there's information about portion sizes. There's also information charts such as the Eat Well guide and Taking the Pulse chart. There's storybooks which all have a hidden meaning within them. There's stickers and reward charts, and there's food and activity diaries and a few other things. So how does Henry work? Henry is a free 8-week session. It's given by trained facilitators who are child health assistants in our trust. It can be delivered one-to-one in a client's home as face-to-face contact or virtual, or as a group face-to-face or online as well in the home. It focuses on 5 specific themes: parental confidence, physical activity for little ones, what children and families eat, family lifestyle habits, and enjoying life as a family. How the sessions are run. So once the facilitator makes contact, receives the referral, she makes contact with the families to build up a relationship. It will either be, as I say, online or face-to-face. So online groups can take up to 12 participants. Face-to-face groups can take up to 8. If it's online, a Zoom link is sent each week, and the family are also asked to look at a short video each week, which is applicable to what the session is about. And each week they're asked to try and make a small change. So the session will start then. I'm going to talk about session 2, obviously, which is about what we eat. So the session will start after introductions and welcome and housekeeping things are discussed. The family will be asked to discuss have they made any changes this week. Then we will discuss the video that would have been sent on session 2 is the Eat Well video, Eat Well guide. So participants will be asked to discuss a typical family meal, and there will be a discussion about how they can improve the content of that meal with better healthy ideas. The next session, part of session 2 is looking after ourselves. And we give an example of a torch. If the batteries are running down on a torch, what happens to the torch when the batteries run down? The torch doesn't give enough light. So this really emphasizes on self-care for parents. The facilitators will really emphasize the importance of self-care for parents without feeling guilty. They discuss ways in which they can make small changes to spend time on themselves, and remind participants that none of us can do a good job when running on empty. So after they discuss that, then they just summarise what the session was about, and again asked to make a small change for next week. So the small changes they would be asking would be to say, try and improve what your typical meal is by food swaps, and also finding something that you can do for yourself, something small. Could be just go for a walk when you maybe wouldn't necessarily do that. Next. So how are we doing in Northern Ireland? So since the beginning of the Henry programme, we have offered it to 1,140 families. We've had 73 groups completed in our 22 and 23 financial year, and 118 one-to-one programmes have been completed in our 22-23 financial year. So from the beginning, we've had 126 groups and 167 one-to-one programmes. So it really started in Northern Ireland. I came into post sort of mid to the end of 21. But by the time we had training, and a lot of the coordinators weren't in post until 22. So that gives you an idea of, you know, how many groups have been offered. So this is feedback from the service users about family lifestyle changes they have made. So we've made quite a lot of changes, including taking bottle away at bedtime, eating new food and sitting at the table and stop eating food as a reward. Giving guided choices and not giving iPads out to my girl, along with monitoring healthy eating in her family. More foods and how active we are. We've cut down on portion sizes, eating together as a family. Everything has improved, healthier choices, less screen time, more outside, less reacting, more responding. All still have a long way to go, but the first steps have been made. I'm going for more walks. My son, who's autistic, is now eating at the table with us at supper time. Before the programme, this was non-existent. Having implemented a more rigid sleep routine, my 3-year-old daughter, who previously resisted bedtimes and woke multiple times through the night, defined family rules and expectations, learning how to interact with your child and come into the world and understanding what they want or trying to compromise with her. There's always something. So as you can see, that's the feedback from the lifestyles. This is feedback from the service users just about the programme itself. The difference, of course, is made. My foster child eats healthily with some treats still and has lots of more energy so thank you again. And that particularly a compliment was to my trust, and that parent had actually sent this compliment in 5 months after she attended the course. And she had a picture of her child sort of before and after. And the child was very overweight, and she showed us a picture to show just how healthy and he looked sort of 5 months after she'd implemented the changes that she'd learned on the Henry programme. Henry has changed her attitude and approach to what we eat, how we can make small changes to our diet that benefits all our family, involving the children in preparing the food we eat and offering choices. Resources provided were user-friendly, informative, great tools to look back at and reflect. When I first started, I wasn't sure what to expect, but Amy highly recommended the programme to me, and I'm so glad she did. Each week I've been able to come along, have a cup of tea, discuss my worries and fears, and realise I'm not alone in this, and other parents experience the same. And then this is feedback from the service users about the facilitators who provided the course. The trainers are very professional. They facilitate discussion but keep the agenda moving. They have been good at providing additional resources and responding to individual needs. The facilitators were lovely and very supportive and gave great advice. The trainers have been wonderful in listening to what we have said and offering informative and useful advice and support. Thank you for spending so much time with me and giving me really useful information. I loved it all. And then this is feedback from the facilitators who provided the course. The group programmes are so enjoyable, and delivering with my colleagues made me feel at ease. Spending time with parents on a one-to-one basis allows me to build a good relationship with them. Seeing changes the families have made each week is really rewarding and encouraging. Thanks for the opportunity to be involved in this. Absolutely loved it, and staff were great also. What a great morning, really positive group, and 8 parents attended. My skills in delivering have really improved. So this is just some of the feedback. There was lots more. Obviously we couldn't put it all into the presentation. So just to finish then, there's 5 trusts in Northern Ireland, and the programme is managed by a coordinator in each trust. And there's the details just of all the different coordinators in each trust running the programme. So thank you for listening.
Thank you so much, Colette. For me, the accounts of the participants on the effect it had on their families was really impactful. I don't see, oh, hang on 1 second. There's one question in the Q&A. Are you happy to answer this now, Colette? The question is, and it's an anonymous question, has the Henry program resulted in changes in the level of children living with obesity?
Well, it has. There is lots of research from England which says that it has, but because it's so new in Northern Ireland, there hasn't been any research completed in Northern Ireland. But certainly, if you go onto the Henry website, is excellent. There's lots of resources on it and lots of information, but certainly in England there's lots of research and which has shown that it has made, especially in the likes of Leeds where it started.
We might share the link to that website later on for participants as well, Colette, so thank you for that.
Okay.
Yeah. If there are no more questions just now, save any more up for the Q&A later on. We might move on to the next speaker. Our next speaker is Louise Reynolds. Louise is the communications manager for the Irish Nutrition and Dietetic Institute, and she's a registered dietitian herself. She's also a member of the Food Safety Authority of Ireland's Consultative Council. Louise has extensive experience working across research for the food industry and as an independent consultant over the last 30 years, and also works as a lecturer in St. Pat's teaching primary school teachers about nutrition. Most of you probably know Louise best as a media spokesperson, and she has contributed extensively across the Irish media over many, many years. Louise is going to tell us a little bit about the pilot scheme for the introduction of hot school meals in the preschool sector. So this is very new and we're really looking forward to hearing about this. Thank you very much, Louise, if you would like to share your slides.
Great. Thank you for that introduction, Aileen. And thank you very much for inviting me to chat to everybody here this morning. And as you said, this is really very current. We're literally, the pilot program just ended last Friday. So I don't have any results. There's lots of anecdotal feedback, but it's a really exciting project to have been involved in. And I'm just going to kind of talk you through what we've been doing, who's been involved, and the kind of feedback that we've been getting so far from the early years services that have been involved. So really the rationale, I suppose, behind the project, I'll have a little chat about that. The nutrition standards, which Fiona has already mentioned as well, for early learning and care services. Oh, I don't know how that, I didn't touch that there, that's okay. Then we'll talk about the pilot sites that were involved, and there's some early feedback and results from the 6-week project. And then really, I suppose it is talking about next steps, how this could be rolled out nationwide, and if it is something that we should be, or that the department should be funding nationwide. Really, I suppose in an effort to improve the nutrition for young children in early learning services around the country. So to just that moving on there for me now. Am I okay? I'll try that. Let's try that one more time. The shared screen. Okay, this is next slide. Is that working for me there? No, okay. We'll move on there. Okay, so Fiona also mentioned this project, and really, I suppose it really, I suppose, the background for the early years project that I've been working on is the school meals, the hot school meal scheme, which, as you've all heard, is being introduced nationwide in DEIS schools from September of this year. And again, the pilot project for the hot meals in primary schools was carried out in 2019. So over the years, more schools were involved, and now it's being rolled out nationwide 4 years later. So with the early learning and care services, we're really just at the pilot stage, but hopefully we would see it likewise, that's something that could be rolled out nationwide over the next couple of years. What did come back to us from a number of parents that were giving feedback was that they have children currently attending primary schools where they are receiving a free school meal, and yet their younger siblings are in the preschool or the creche next door, and the parents have to send in maybe a lunchbox with that child, or they're not getting the same free school meal. And they've really found that there was a difference there, and wouldn't it be great if this could be rolled out right across the board, not only once the child starts primary school at the age of 5. I just took some comments here to which were in one of the newspapers when the project was rolled out or was announced by Minister Heather Humphreys. And you can see there the first two being really positive. I firmly believe it aids concentration. Socially, it's having a massive impact. That really is referring to the children eating together at lunchtime in school. And that's something that has become really apparent in our study as well, in our pilot project as well, and I'll mention that later on. One of the schools found the younger classes are less enthused, so I don't know why that was. They didn't give too much more detail, but again, you know, you can see that as the older children are really active in school, maybe a really hot meal is important for them. And in terms of the waste at the moment is absolutely shocking. What that referred to was portion size. So that has been addressed within our project, because in this situation, the 6th class children and the junior infants children were getting the same size lunch. So obviously that needed to be tweaked. So now that has been changed for the DESH School Meals program, which is being rolled out in September of this year. And there are different size portions, you know, kind of half portions for the younger child. So again, there's a lot of learning, you know, with any of these projects as they're coming on stream. And similarly with the early school years, we found that there were lots of tweaks as we went along during the 6-week program. Next slide, please. I'm not sure if that's working. Thank you. Thanks, Laura. So again, the reason for implementing the free school meals is, I suppose, the research there to show that for children who are experience educational disadvantage, nutrition is really, really critical. I mean, we all know nutrition is really important for children who are growing, but also for their concentration, for their attention in school. So we found in this survey of the primary schools that the free hot meal for some children was the only hot food that they would receive all day. So again, you know, for these children who are suffering, you know, food poverty, social disadvantage, you know, anything that we can do to improve their nutritional outcome is really, really important. And again, that's really what the whole program is about, encouraging, you know, children, or ensuring that children from a very young age are not disadvantaged when it comes to nutrition. The next slide, please. So when we look at then the nutrition standards, which were just launched in May of this year, on the 4th of May, and these are available on the gov.ie website. And this really became, I suppose, the gold standard for the pilot project that I was working on. So the aim of these nutrition standards for early learning and care is to inform, develop, and implement healthy eating policy and practice in early learning and care services. This is to ensure the promotion of healthy foods and drinks in main meals, snacks, and celebrations are agreed in partnership with children, parents, service providers, and the wider community. So this was really, you know, when we were going in to visit the services, we were bringing in a copy of these new standards. We were going through it with them. We ensured that they were referring to this when they were making changes to menu plans. If there's any questions or queries, they could check the standards. Also then, with the 6-week program, what was very unique was that they did have access to a registered dietitian, which they all found really, really useful. Next slide, please. So just to give you an idea of where we went, and there were 9 services which were involved in this pilot program, 7 from an urban setting and 2 rural. You can see there were 5 counties involved. Now, I'm not sure, hopefully my dots are in the right places because they were kind of moving around on me, but you can see here we had 3 in Dublin, 1 in North Dublin, up in the North Dublin Fingal area, 2 in the inner city. Then in Wicklow, we had a service in Blessington and in Bray, 1 in Kilkenny, 1 in Westmeath, and then 2 down in Cork. So in terms of social disadvantage, 6 of these services were classified as marginally below average in terms of their level of disadvantage, and 3 were classified as disadvantaged services. And 8 of the 9 were community not-for-profit services who were already receiving funding from Pobl. So Pobl were involved in this project as the project managers and looking after the funding and allocation of funding throughout the project. Next slide, please. So just quickly, the methodology was that all of the 9 services were visited by myself, a registered dietitian, and the project manager from Pobl, who was dealing with the funding side of things, explaining what was needed or what was available in terms of funding allocation. And we spent really between 1.5 to 2 hours within each service. An on-site nutritional assessment of the current menus was carried out, this was really a visual assessment and a conversation, having a look in fridges, having a look in freezers, kitchens, to see what was available, having a look at menus and making healthy suggestions. The funding was explained, and they were the services were told about what they could apply for within the funding framework of this project. The 6-week pilot was carried out. It started on the 2nd of May, which was just the day after the May bank holiday weekend, and finished on the 9th of June. Yeah, the 9th of June. And then there were fortnightly calls during the pilot and pre and post evaluation questionnaires, which as yet haven't been fully collected, and both managers and staff within the services were surveyed, and also parents. So it should be really interesting to see, you know, from both sides how things went in terms of feedback, changes to, you know, the food that was being offered, and so on. Next slide, please. So I just included here just 2 sample menus that I took just photographs while I was there. You know, these were just kind of very top line menus that the services were offering to the children. Again, there was, I'll mention in a moment, there was a whole range. Some were offering hot meals, some weren't. There was a variation between the 9 services, which really will reflect early care services throughout the whole country. So you can see there, you know, pasta on a Monday doesn't really give much more information. In a lot of cases, there was, you know, children would just want plain pasta, or there might be pasta with a tomato sauce, maybe pasta with a bolognese. Then you had things like fish fillet, chips and beans. That fish fillet would have been a frozen breaded fillet. Again, breaded chicken another day, sausages and chips another day. So a lot of foods there that, you know, there was certainly a lot that was really good that was going on, but also some room for improvement in terms of nutrition for the children. The other one there you can see on the right hand side, on Monday it was coddle. So I probably should explain that to you, to those of you maybe who are joining us from the north of Ireland or outside of Dublin. Coddle is a really traditional old Dublin dish, and it's really a white stew. If you can imagine, there's no colouring in it. It's kind of very pale, clear liquid almost, with the potatoes in it, some carrots, and the meat in it is sausages and rashers. So it is really a very traditional Dublin dish, and it was quite popular, with this service telling me that it was, you know, the children all loved it, but there were lots of kind of pale sausages and rashers in there. So again, you know, something that could be improved a little bit in terms of maybe going for a lower fat option. Shepherd's pie, you know, great meal there with vegetables, fish fingers again. So just if you go on to the next slide, please, we used the nutrition standards as a template. So again, going back to that document, which is really, really useful. And for any of you who are interested in kind of looking into this in more detail, it's a fabulous reference document, which is based on the FSAI guidelines for 1 to 4 year olds. So it really, you know, this is just a snapshot I took here talking about treat foods, fizzy drinks, you know, portion size, again, smaller stomachs for children, and, you know, the importance of milk in the diet of young children as well. Next slide, please. Again, this is just a picture that was taken in terms of the fruit and vegetable guidance. Some of the feedback came back that, you know, just to the service managers and the staff were maybe not, they knew fruit and vegetable was important. They kind of thought maybe just having 1 piece of fruit and vegetables in the day was okay. But again, the nutrition standards gives very strict guidelines for depending on the length of time the child is spending within the care service. So again, you know, some children are just there for the free hours in the morning from maybe 9:30 to 12:30. And some children are there for longer. There were some children who would be there for the full day. There were, you know, some of the services provided full day care for parents who are working. So it really varied a lot. Some of the services, the staff were aware that when a child would leave at lunchtime, that really they were not going to have another hot meal later in the day. So they were really without, I have to say, absolutely all of the services were fantastic in terms of what they were offering to the children, the level of care, the level of concern, and really it was, you know, it was absolutely fabulous to see the care that was provided. And then we just came in to see, okay, can we improve that nutrition offering as well as the fabulous care that the children were getting in all of the services. The next slide, please. So things like simple swaps that we suggested here, for example, the sausage casserole, we were talking about maybe a beef stew. Again, these are more expensive. To buy beef is obviously more expensive than buying sausages. In terms of fish fingers, we said maybe we could try baked salmon and mashed potato. Salmon is obviously more expensive. So this is where the funding for the 6-week pilot project came in. So not only were the services getting nutrition advice, they were also getting the funding to allow them to make changes to the food that was being offered. Another example, the baked salmon and mashed potato, there was a lot of, I suppose at first the staff were thinking, oh, I don't think they'll eat, oh, they wouldn't eat salmon, they'll never eat salmon. We encourage them to give it a go, and the feedback so far has been they're loving the salmon and mashed potato. So again, sometimes the perceptions of what children's foods are versus what are adult foods is something as well that we spoke about, and just to encourage the staff themselves to kind of say, okay, we'll try this. And what the funding also allowed was to try something, and if it didn't work, to try something else. Because obviously, if you're managing a very tight budget for a childcare service, you are not going to spend money on foods that are not going to be eaten. So that was something that we found again and again. The pilot project allowed people the flexibility to try something a little bit different. You can see at the bottom of the slide there, the Safe Food 101 Square Meals cookery book, which is again a resource which is available online on the Safe Food website. But we were very lucky that Safe Food provided us with a physical hard copy. It's a really beautifully printed and colourful cookery book, and that was available for all of the families throughout the 9 services as well. So when the parents were receiving a note about their children taking part in the pilot, they also received a copy of this lovely cookery book. And then the children were able to tell them, oh, we had something from the cookery book today in school. So it worked really well. Something else to be aware of was we did find that within the disadvantaged schools, some of the parents were illiterate and weren't able to try recipes from the book. So that's something else that we obviously need to keep in mind for going further with projects like this. Next slide, please. In terms of the funding, so this is the department's school meal rates, and that is the amount you can see there, which is provided for either a breakfast, a cold lunch, a dinner, or a hot school meal. And these are the rates which were provided. So for example, the amount was calculated based on the number of children that were being provided with, for example, a breakfast or a hot school lunch or a dinner during the day. And so, for example, if there were 20 children, this figure was multiplied by 20 per day over the 6 weeks. So it really was quite a substantial amount to support the services in providing hot school meals. In some cases then, and I'll mention this in a second, it was actually hot school meal is a little bit of a misnomer because some of the schools were providing more nutritious cold meals instead of children bringing in food from home. So I'll mention that in a moment. As well as this, in the pilot, there was also some seed funding to allow purchase of new equipment. So for example, a slow cooker. And one of the services said to us they would love to have done a beef stew, but they didn't have the time to prepare it. So by allowing them to have a slow cooker, this was something they were able to provide to the children. So there was that funding as well. Also funding to buy new plates, child-sized cutlery, allowing children to kind of self-service, go up and maybe pour things themselves, all of those skills that are really important as well in the early years. Next slide, please. Okay, so you can see here that only 3 of the services in the 9 had working kitchens. They had kind of stainless steel, fabulous HACCP trained staff there. Everything was set up in order to allow them to change the menu and to still provide hot meals. The other 6 were not providing food at the moment, and the parents were sending in food every day in lunch boxes for the children. So the quality varied really widely in terms of what the parents were sending in. All of the care services had a healthy eating policy, but often, as the year went on, it was not followed. The parents were busy. They were, had lots of things going on. And very often they found lots of convenience packaged foods were slipping into the lunchbox. Again, there was huge variety, and this kind of made children feel often a little bit different. So you had maybe one child who had, a sandwich and a piece of fruit. Somebody else might have had a packet of crisps and biscuits. And, they were saying, why do they have that? Why can't I have that? So there was, that kind of issue arose from time to time. There was one child in one service in particular who just brought in a packet of biscuits on a Monday, and that packet of biscuits was his snack for the 5 days. So he would have maybe, 3 biscuits on a Monday, 3 biscuits on a Tuesday, and so on. All of the services in all of the services involved, they did have backup food there. So they had breakfast cereals, or they could provide toast, for children who were hungry, or if children forgot to bring in a lunch or didn't have, if the parents hadn't sent in a lunch that day. So there was a wide range of I suppose, backgrounds of the children. And, without fail, the staff were really, very aware of this. And in some cases, they would provide breakfast for maybe a few children in the morning if they were aware that those children hadn't had a breakfast at home. And what the pilot project allowed was that it became really inclusive. So all of a sudden, every child was getting exactly the same. In one of the services, they were able to open up a breakfast bar for every child. So every child was able to have their breakfast in school during the 6 weeks. So lots of real positives in terms of inclusivity, not having any child feeling different or othering any child in any way. So that was all really, really positive. Next slide, please. Okay, this was just one of the surveys, the pilot survey, which is currently being analysed. I just got a couple of graphs to share with you. And this one here is from the staff who were talking about the factors that influence food purchasing. And as you can see, their costs came out on top. So, it really was a huge factor in terms of what the services could offer. Was the cost of food. So they really felt it was just a huge relief for this pilot project that they were being, funded, and they were able to try new things and try different things with the children. Next slide, please. Okay, I've really kind of highlighted there. In certain services then, hot meals were delivered in, and these were some of the same providers that were providing the hot meals to the primary schools, which were in some cases just next door or just in the next town. Again, there was a little bit of work at the beginning, and we spoke to the service providers, the hot meal companies, the delivery companies, and they were doing much smaller portions for the preschools, because again, that issue of waste was something that had been highlighted. Cold lunches were being prepared in-house by some of the services, and others then were bringing in cold lunches. So it really varied very much depending on space, if they had a fridge, if they were able to, for example, keep yogurt somewhere cold and safe for the children to have. And then in terms of the improved offering, I've mentioned some of those already: oily fish, lean meat, yogurt and fruit breaks, berries, fresh fruit and vegetable platters. This became really popular, and it was to allow the children, again, to sit around together with their classmates, and self-serve from kind of platters of different kinds of foods. They also did lots of work and lots of learning stories around this. So the children were talking about foods, where foods come from, foods they'd tried before, foods they hadn't tried, and so on. And again, it was a really supportive environment. So none of the children had to finish foods, because as we all know, it can take a child up to 10 to 15 times to accept a new food or a new taste. So we weren't expecting children to kind of, see a food they'd never had before. For example, watermelon was one that a lot of the services tried out, and the children had lots of conversations around it. But, kind of by the time they really enjoyed it, and it was something very new that they hadn't tried, and probably a lot of them hadn't tried it at home either. One of the feedbacks that I got on our calls was that celery is not popular. So as much as I might try to get them to have hummus with vegetable sticks, I wasn't getting nowhere with the celery. It definitely wasn't working out. But again, that was just, trying different things. The carrot sticks worked really well with the age appropriate children, dipping them with hummus, having some cream cheese, having breadsticks. So it was all about just having the space and the time and the funding there to try new experiences and new foods with the children. Next slide, please. And again, this was another, just some feedback, some preliminary feedback. You can see there that the current kitchen equipment in 3 of the services was unsatisfactory or very unsatisfactory. And again, this is going to be replicated nationwide if this project is rolled out. So there are lots of issues in terms of, how do we manage that? In this program, the public funding did allow some purchase of fridges, a larger fridge in one particular case, a potato peeler in one of the services, where the chef in-house, so there was a lady who was working there purely to cook for the children, but she was spending about an hour and a half peeling potatoes. So a potato peeler, an industrial potato peeler was purchased in that case. And again, would you be interested in learning more about nutrition and healthy eating? So 8 out of the 9 services there said yes. And that is something that they all came back and said they found really, really useful, was having that content, you know, in terms of things being explained to them. Because at the end of the day, the managers and the staff have a small amount of nutrition training, but really they're also consumers. They're picking up their nutrition information from just where everybody else is getting it, online or TV advertising, or, you know, just kind of picking up a magazine. So that is something that they found really useful, was to have the one-on-one. And I suppose long term, we would like to look and see how could that be rolled out nationwide, to kind of bring people up to speed with nutrition training. Next slide, please. And I'm just keeping an eye on my time. Okay, so this is some of the feedback here: improved nutrition, social skills, eating with their peer group. Again, children with sensory issues. Most of the services had one or more child there with a whole range of sensory issues, from, you know, just children not trying new textures or tastes of food, right through to children with ARFID, who really had a very limited diet. And in some of those cases, the changes have been quite dramatic. Parents, you know, couldn't believe that children were, after the 6 weeks, trying a new food, eating something they hadn't eaten before, even sitting with their peers, rather than just eating what the parents had sent in the lunchbox. So really, really positive from that point of view. The parents obviously enjoyed not having to send in food, and any of us who are parents will certainly get that. Not having to make a lunchbox in the morning and not checking the fridge the night before to say, oh, what can I put in the lunchbox tomorrow? So that was something that the parents really were very positive about. And in fact, and because we're coming up to the end of the year, the academic year for the ECI services within the preschools, the pilot program has given an extra 2 weeks funding to allow the services to continue with the pilot program right up until the end of June. So that means then that they, you know, they have kind of said, oh, what will we do in September when we go back, and we have to go back to the old ways. But they certainly were, you know, will be making changes ongoing to their menus. But in the cases where they're not providing food, you know, the parents will be going back to sending in school lunches. So there's definitely, you know, ways that they can probably, you know, encourage the parents to keep going with the new foods that children have tried. Next slide, please. This was just a photograph that was sent in to us from one of the services, Funny Face Friday. So you can see here that they were providing new colourful plates for the children: mandarin eyebrows and mouth, cheese nose, apple ears, yogurt and blueberry eyes, all of which makes Funny Face Friday. The kids will be doing it themselves next Friday, so I can put my feet up. So again, this just gives you an idea of one of the biggest issues, which was the time. So, you know, obviously there's a lot of work in preparing that. You know, beforehand, the children would just be opening their lunchbox and having a piece of fruit if their parents had sent a piece of fruit. On this occasion, they're making a whole activity out of it. It's great that the children then will be doing it themselves, but there's a lot of preparation there. You're peeling fruit, you're chopping fruit. So all of that needs to be taken into account. Next slide, please. Sorry, next slide, thank you. Okay, so this is the biggest drawback. So if you can imagine, in some of the services where the parents were sending in the lunchbox, all of the staff had to do was open the lunchbox and sit down with the children. Now they need to make a shopping list, going to the supermarket or doing online shopping, storing all that food when it arrived, you know, finding places to put it away, preparing the food. So this, while they were very enthusiastic for the 6 weeks of the pilot, going on long term, they all agreed that wouldn't be sustainable. They would need extra kind of hands on deck to carry on doing that level of food prep, really. And they kind of agreed that an extra staff member would be needed probably 2 hours a day. So during the 6 weeks, so before the 6 weeks pilot, I visited all of the 9 services. Then we had a Zoom call with all of the services before the project began. That was really good because they also all learned from each other. They all kind of gave each other ideas of what they were going to do and what they tried. During the 6 weeks, we had a call every second Friday. So we had 3 calls during the 6 weeks, and we actually have another call this Friday, just to kind of regroup again and see what worked, what didn't. And then the surveys will be getting kind of written feedback, and we'll all be writing up reports on how it went. So at the moment, as I say, it's just literally finished, and the anecdotal feedback has been really good so far. Just my next slide there, I just want to say, I think yeah, and the next one there, I've just kind of mentioned that already. Okay, so I think this really happy looking guy, I think, just gives you an idea of, you know, the feedback from the staff and the children involved. It's been a really lovely project to work on. I just wanted to kind of thank all of those people there who were involved at various stages with me. So, you know, it would be fantastic to see this rolled out. There are certainly challenges to doing that, but you know, it's definitely something that we'd love to see every child around the country getting the benefit of this. So thank you for your attention. Thanks, Aileen.
Thank you, Louise, and thanks for bringing the project to life for all of us. I can see that there's a few questions in the Q&A, but just in the interest of time, we're going to hold those, if you don't mind, until we have the Q&A session later on. I'm going to move rapidly to the next speaker. Unfortunately, Dr. Anna Lene Seidler is not with us in person, but she's kindly sent us her presentation as a recording. Where she is, she just can't get a good connection at the moment, so we're lucky to have the recording this morning. She's a senior research fellow leading the Next Gen Evidence Synthesis team at the National Health and Medical Research Council Trial Centre at the University of Sydney. Her key interest is in bringing researchers together across the globe to promote human health, and she's leading a number of projects in the area of child health, particularly in the early years. One of those is Top Child, Transforming Obesity Prevention for Children, and another is EPOC Translate, which focuses on enhancing the effectiveness and translation of early childhood obesity prevention. So we're really looking forward to hearing about, I suppose, where the current evidence is and where we're going in the future. So please play, Laura, Anna Lene's presentation. Thank you.
Hello, and thank you so much for having me today. My name is Anna Lene Seidler, and I'm based at the University of Sydney in Australia. I will talk to you today on the complex quest after preventing childhood obesity, what we know, and where to next. I would like to acknowledge the traditional owners of the lands that this research was conducted from, which are the Gadigal people of the Eora Nation. 1 in 4 children in Australia have overweight or obesity by the time they start school. And the picture in Europe and the US is looking very similar. So if we want to prevent childhood obesity, we need to start very early, when the biology is most amenable to change and before children enter a negative health trajectory. However, what's still unclear is whether early prevention is effective and whether it reaches the populations that's most needed. And that's something I aim to address in my research, and I will cover in my presentation today. Now, what we first did to find out whether early interventions are effective is we combined 4 trials in Australia and New Zealand that all conducted behavioral interventions that started in pregnancy or within the first 6 months after birth. What we did is we conducted an individual participant data prospective meta-analysis of these trials with over 2,000 children in total. Now you may ask yourself, what is an individual participant data meta-analysis? In an individual participant data meta-analysis, data from each trial are collected raw, row by row, instead of just scraping data from publications. And that is seen as the gold standard for meta-analysis. It leads to higher data availability and quality, allows some harmonization across studies. For example, we could harmonize BMI-Z score, and allows more complex analysis, such as subgroup analysis. So I would like to explain it in these pictures. On the left-hand side, you see an aggregate data meta-analysis. We have to scrape data from publications, so all those colorful participants turn into a gray average effect estimate, whereas in an individual participant data meta-analysis, we retain the color from all these beautiful colorful participants and can, for example, look whether an intervention works better for red participants than blue participants. You may also ask yourself, what is a prospective meta-analysis? In a prospective meta-analysis, studies are identified as eligible for inclusion before their results are known. So you can see here in the diagram, we have 3 studies, and a prospective meta-analysis is anything that's planned while the study's in their planning or recruitment phase, but before their analysis are undertaken. And that allows us less biased analyses. So we reduce the risk of publication and selective outcome reporting bias, harmonization of outcomes. So trials can decide on which outcomes they're going to collect collaboratively. That increases statistical power, and it's in general a collaborative undertaking. And if you'd like to know more, we've published quite extensive on this great methodology and the advantages. Now, coming back to the EPOC collaboration, where we brought together 4 trials from Australia and New Zealand, what you can see here in this table on the left-hand side are the number of outcome categories that were collected by each of the 4 trials. You can see a lot of the outcomes were only collected by 1 or 2 of the trials. On the right-hand side, you can see what happened after the trials decided to collaborate, work together, and harmonize their key outcomes. Now, suddenly, most of the outcomes were collected by all trials. So we went from only 2 out of 11 outcomes being included by all trials before PMA inclusion to 10 out of the 11 trials, because the trials decided to work together. So, and this is what the EPOC perspective and analysis looked like. So the trials learned about each other when they'd just been funded, decided to work together. We formed the collaboration, we published a protocol, and then once all the trials had completed their 2-year follow-up, we brought them together both after 2 years and after 5 years to assess overall effectiveness. And this is what we found. At 2 years of age, we found that early obesity prevention interventions led to a modest reduction in BMI-Z score, which was statistically significant. It also led to some improved health behaviors, such as prolonged breastfeeding, reduced screen time, and reduction of some undesirable feeding practices. We also found that the interventions were more effective in populations that had limited existing care in the community. However, we still didn't really know what all of these interventions entailed. So we knew that the interventions actually differed in their effectiveness, and what was in these interventions remained a black box. So each of them had used different behavioral approaches, and we didn't know what they used. And that's why we conducted an additional study in which we brought together the 4 EPOC interventions. We deconstructed them into their components, looking at target behaviors, delivery features, and behavior change techniques. And we conducted interviews with the intervention planners and facilitators. And these are our key findings. We found that the interventions were indeed all quite different from each other's. They were diverse, complex in their content, behavior change strategies, and delivery, which led us to the questions, now, which of these different strategies, which of these intervention components actually make an intervention effective? Which interventions work best and for whom? And that is why we decided to bring together the Top Child collaboration. So Top Child aims to bring together all completed, planned, and ongoing trials internationally on early child obesity prevention, to find out which intervention components are most effective and for whom. And if you like to think about it in Duplo language, we have all these colorful building blocks, and we sort them into their different colors and components, so we understand what's actually in those beautiful interventions, and then we can realign them for each of the participants. So each participant gets the kind of intervention that works most effectively for them, or each participant group in this case. And this is how we were planning to do this. So first of all, we conducted a systematic search for all eligible trials internationally. So all early child obesity prevention trials starting within the first year of life. We then collated the individual participants' data as done for EPOC, but on a much larger scale. The trials that were ongoing, we brought together in a prospective meta-analysis as well. We then used a range of taxonomies to deconstruct the interventions to understand their components and look into that black box. And the last step is to bring project 1 and 2 together. So to use the individual participant data, to use the different components to identify the most effective intervention components for different population groups. And this is where we're up to. So we've conducted our searches, screened over 10,000 records, and we're updating these searches annually. And so far, we've found 50 eligible trials that have joined Top Child with over 40,000 participants internationally. So there are a lot of trials in this space taking place internationally that are willing to collaborate. And here you can see all our different trials. So we are a truly international collaboration. However, 88% of the trials were set in high-income countries. And knowing that obesity is an emerging problem and a rapidly increasing problem in lower and middle income countries, there's room for more interventions there. Now, when we looked at what kind of populations do these interventions target, we found that the majority of the trials targeted universal populations within the country, and only 26% looked at specific priority populations. Now, that is important because obesity is a health equity problem. So it is important to think about targeted interventions for these priority populations. We also found that interventions differed in their effectiveness. So only 27% of the interventions reported a statistically significant difference for an infant weight-related outcome. However, some of them were underpowered to do so. So it'll be really interesting to see what happens when we pull them together in a meta-analysis. And as we've seen for the 4 EPOC trials, on a larger scale, we also found the interventions were actually all quite different from each other. So here you can see, for example, some were face-to-face, whereas others were online. Some were in a home setting. Some had quite frequent contacts and others did not. So we still have quite different interventions. So it's really worthwhile to then understand which one of those work best for which population. They target a range of behaviors. So some target infant feeding practices. Most targeted some kind of food provision, but not all of them. But half looked at movement practices, early movement, and only less than 20% also included sleep practices. So again, some variation in intervention content here. So let me give you a quick summary of the landscape of Top Child trials, the landscape of early childhood obesity prevention trials we identified. We identified there was a vibrant trials landscape there. However, most of these trials were in high income settings. Most target universal populations and not priority populations. So there may be some room for more interventions looking at populations that most need them. Not all of the interventions were effective. And that's particularly relevant because we know they all differed in their delivery features and target behaviors. So now what's next? The next steps are to do these formal analyses to be able to answer which interventions work best and for whom. I'd like to take one step back though to talk to you about one limitation of these interventions I haven't covered yet. So now we're doing a little detour back to the EPOC prospective meta-analysis of the 4 trials, where I showed you these very promising results of at 2 years of age, we found overall the interventions improved weight-related outcomes. And now with Top Child, we may be able to show which interventions are most effective and even increase its effect. However, what happens with the 4 EPOC trials over time, we found that this effect actually faded out over time. Now, I don't think that's surprising because children do grow up in an obesogenic environment. And once they grow out of their family environment, they have broader sources of influence. So they may start preschool, they may go into daycare. So I would interpret this not as early interventions are not effective over time. I would interpret these findings as early interventions alone are not enough. We need a life course systems approach, need a suite of complementary interventions across multiple stages of childhood to not for the intervention effects to not fade out. And I think one point that's really important there is also to move beyond the micro level. So to consider approaches for setting and regulatory approaches, particularly once the children go out of their immediate family environment. So early interventions are not enough. They need to be part of a suite of interventions spanning the life course and different settings to prevent fade out effect. All right, so that brings me to the end of my talk. So what do we know so far? We know that early behavioral interventions can be effective. However, they vary in effectiveness and content. And we have developed innovative collaborative methods that can help decipher what works and for whom. And another key point is, I think, that working with policymakers and consumers throughout the research project is key. And that's something we are doing as part of the Top Child collaboration as well. So hopefully soon we will be able to give you some more conclusive results on what it is about the different interventions that make them effective and for which populations. I also left you with a bit of a cautionary note, though, that early behavioral interventions do fade out and that we need to think about life course and system levels approaches, setting and regulatory approaches. I'd like to leave you with a quick note about the power of collaboration together in the Top Child collaboration. And these are all the different, these are a lot of our different trialists that have agreed to collaborate. We can answer questions that no single trial or simple meta-analysis alone would be able to answer to ultimately address early childhood obesity. And that is truly wonderful. I'd like to thank the Top Child steering group as well as the collaborators. And I'd love for you to get in touch with me if you have any questions. Thank you so much.
And I'd like to thank Anna Lene in her absence for, I suppose, introducing us to how powerful that kind of collaboration can be, so that the data can answer much more questions than in previous time, and we can learn much more about what's effective in the preschool settings. We're going to move very rapidly to our Q&A. We only have probably about 8 minutes. I can see that there's lots of questions, but if Colette and Louise would be ready to answer a couple of questions, that would be fantastic.
No problem. I was having a look through some of them there as well. So yeah.
Great. Is there anything you picked out, Louise, that you want to get started with?
Yeah, I suppose one question there, maybe I was a little bit confused. Somebody asked, in primary school, the service is contracted out, so the food comes prepared, and in preschool, is the cooking going to take place on site? Well, really, it's going to depend very much on the service. So within the 9 services in the pilot, 3 were already doing their own cooking. So obviously the services that didn't have any facilities, we weren't expecting them to start cooking a hot meal. So it does vary. And I think that will be the same nationwide. So if there is a kitchen already there, then the funding would be used, for producing higher quality food on site. However, if that's not available, then it will be a matter of contracting in either hot food or cold food that's more nutritious. Really, it's going to be very varied. So there's going to be lots of different options, would be the way it's going from just the pilot so far. So it's not going to be a one size fits all. It will be, whatever will work for the different services. So I hope that answers that. And the other question about food waste, that from Mary there, yes, we did talk about food waste because, again, they were buying in a lot of fresh fruit, berries, vegetables that maybe weren't going to be eaten. So actually anything that was left over, a number of the services were doing smoothies on a Friday and using any leftover fruit. And similarly, they were making a vegetable soup as well, if there were vegetables left over. So they were very conscious of that. And in fact, in one of the services, which was in a rural setting, one of the parents had a farm and they had some pigs. So they would keep taking all of the peelings and all of the kind of extra leftovers and feeding them. So the children then were learning about that as well. That became another learning story for the children within the service. That was really, really useful as well. Was there something else there?
I might ask Colette a couple of questions while you're having a look there, Louise. There's one question there on the conversations and the approach regarding the differentiation between body weight and health. These are some of the tricky conversations, Colette, you might have with a parent as you're running the program. Can you give us a little bit of insight as to how that conversation takes place?
Is that for the referrals, or if those conversations, is this to refer the criteria for referral? I think because during the, I suppose during the program, we wouldn't get into talking about body weights and things. So I think that's maybe the referral process. And I suppose health visitors, which would be the equivalent of your public health nurses down south, they do developmental assessments with children at various stages where they would do weight and measurements. So that's how they would work out, you know, that a child is, you know, 2 centiles above their weight, you know, if they're their weight is 2 centiles above their weight and things like that. Is that what the question's about?
It was probably more about that nuance of whether, I suppose it's a little bit maybe about the framing of the conversation, whether you're talking about child health or whether you talk directly about weight to the parent at that point. And I suppose if it's at the point of a measurement program, you do have that.
Yeah, we would measure our children. So we would be saying,
yeah,
you know, your child is 2 centiles above, you know, so that's how the conversation would be approached and approached during that assessment. And then they'd be talking about diet and, you know, what is the diet? And then I suppose the program would be introduced then at that stage.
One more question for you, Colette, and I was very curious about this myself. One of the criteria was that kind of willingness or readiness, wasn't it, to change?
Yeah.
And how do you assess that?
Well, the health visitors, Henry offer training to the health visitors, school nurses. It's called Raise, Engage and Refer training. And although they, you know, it's accepted that there's no magic formula for overcoming resistance for change. I suppose the training very much focuses on getting the parents alongside them, building relationship based on trust and respect and empathy and listening to them. And health visitors would have the conversation about, you know, what they would recommend. And it's really up to the parents whether they want to, you know, take that advice or not. Sometimes a referral is sent and when it's offered to the parents, they don't take it. And then you might find that, you know, 4 or 5 months later, the health visitor or school nurse, whoever the referrer is, will come back and say, look, I know I'd referred this family earlier and they turned it down, but they really feel now that they're ready for that change and that intervention. So it's really, you know, just they say that you have to offer something loads of times before people, you know, could maybe accept it. It's a bit like food. You have to offer a child, you know, maybe something 10 times before they actually like it. You know, you can't just rule it out after the first time. So again, it's just building that relationship, and it's all about building relationships and trust and respect and their wishes, not, you know, lecturing them and just listening.
I am conscious of time. We only have 10 minutes left, and I really want to hear what Darren has to say to wrap up. Could I ask the speakers, would you be willing to write some of those responses in a written format that we could give that feedback to some of the participants later on? Would that be possible? Just because I'm conscious we have lots of questions and we're just not going to get to all of them.
Yeah, and I'm just typing some answers into the chat box.
Oh, great. Thank you, Louise. Thank you.
Okay.
Brilliant. Okay, I want to thank everybody so much for their participation. We have an overwhelming number of questions that we can't answer, which is always a really, really good sign. It's been a fantastic session. I have really enjoyed the talks and learned a lot myself. Thank you all. Thank you to our speakers. Thank you to our colleagues at the department. And one last thing is to hand over to you, Darren, for your closing remarks. Thank you.
Good morning, everyone. I'm Darren Moan, and I'm the Obesity Prevention Policy Lead in the Department of Health in Northern Ireland. And as you heard, I've just been asked to give some brief closing remarks to wrap up this morning's webinar. Louise Reynolds' presentation on the nutritional issues and outcomes of the pilot study, Hot Meals Scheme for Preschools in Ireland, and Dr. Lene Seidler's recorded presentation from the other side of the world on what works and for whom in early years childhood obesity prevention, as well as the research gaps and the opportunities for further study and collaboration. And many thanks to all of you who have attended this morning's webinar and for your questions, engagement and enthusiasm this morning. I think we've covered a lot of ground today, and we hope we've answered some of your questions and queries both here and through Twitter. In Northern Ireland, we're currently developing a successor obesity strategy for obesity in Northern Ireland to replace our A Fitter Future for All obesity prevention strategic framework. And the ongoing programmes and research discussed today will inform and support the strategy going forward. Many thanks to colleagues and stakeholders online with us today who have worked hard to develop and progress this with us over the last 18 months. And we're continuing to work together through the All-island Obesity Action Forum to tackle obesity across our island and to try and change the environment in which we all live, grow and develop to move towards a healthier and fitter future for all. Once again, I'd like to thank everyone for taking part this morning, and I hope we can continue to work together to build a healthier environment for all our children and for all of us here today. Thanks for taking time out to attend the webinar today. Thank you.
Thank you, Darren. And with that, we will bring our webinar to a close. Take care, everybody.